Welcome back from lunch. I'm Jay Keese, Executive Director of the Direct Primary Care Coalition, and thank you. It's a pleasure to be here in San Francisco with our friends from HINT. By the way, big landmark year for the DPC Coalition this year. We actually migrated onto the HINT platform, which is the best thing that we were able to do for our group. Really cut down on administrative expenses, and now we're actually one of those millions of points of lights in Zach's little display, so really excited about it. But, you know, DPC is revolutionary. Who doesn't believe DPC is revolutionary, right? We're here to talk about the revolution, right? So, I know it's revolutionary because I'm a patient. It's completely revolutionized the way my family gets care. My daughters are away at college, and they don't go to the health center. They call Dr. Matt or talk to him on the Spruce app. And it's completely changed that behavior for us and for, now hundreds of thousands of people around the country. And thanks to a lot of the good work from the people in this room, people understand what the revolution is about. People understand that the revolution means you'll have a personal relationship with a doctor instead of having the doctor get paid to do stuff to you. People understand that the revolution means we're potentially going to save millions, maybe even billions of dollars on unneeded administrative expenses that you don't need with direct primary care because you're paying for everything in a simple monthly bill up front. And, the revolution is growing. Employers like Boeing, the New Jersey and Nebraska state employees funds, the corner store, the grocer, the trucking company and the craft brewery that were talked about earlier today. These people all realize now they can get better care, better benefits for their employees, and it's a major change in the way people think about their care. So it's growing, but everybody's not happy about this. I mean, most people are happy about it. When you hear about it on the news, the news is good, but every time there's a change in the way we deliver healthcare, there's going to be winners and losers in these revolutions. There's going to be a lot of things that used to get paid for in expensive specialty care and hospitalization that don't anymore. It's going to cost some people some money and some people some jobs. So, we've got to really think about how we move forward with our message. And I'm an old history major, so I thought we'd pull this out. Ben Franklin had this to say as the revolutionaries in Philadelphia gathered and tried to decide, whether or not they were going to take on the British Empire. So pretty big deal. But, we must indeed all hang together, or we most assuredly will all hang separately. So when it comes to government regulators and insurance commissioners and the Department of Labor and all these different groups, not to mention CMS, we'll talk about that in a minute. People are watching and they're paying attention. So, revolutions that are successful have a few things in common. Number one, they have unity of purpose around a common set of ideals. We, the people, in order to form a more perfect union. Notice it didn't say we, the people, in order to form a perfect union. It said a more perfect union. Don't let the perfect be the enemy of the good. So let's take a look at some revolutions. The Arab Spring, we got rid of all the leaders. We couldn't decide whether we wanted secular government. We couldn't decide whether we wanted, women to have a voice or a role at all. Zhou Enlai, the revolutionary in chief in China, when Nixon and Kissinger, I know Gil Scott-Heron promised there would be no pictures of Nixon, but I'm sorry, I just had to have this. But they asked Zhou, who had studied in France, if he thought the French Revolution was a success. And he said, I don't know, it's too early to tell. Perhaps we can talk about it in another 100 years. Revolutions take time. So let's look at the revolution that's happened in DPC, and this has happened over 10 years. When we formed the Direct Primary Care Coalition in 2009, 10 years ago, there were 21 practices, we were about 100 practices that we identified in 21 states. And we put them on the map to show the world that, hey, this isn't just Q Alliance or a couple of practices in Washington State that are doing this. This is a movement, and it's growing. Shift forward 10 years, 1,000 practices in 48 states, growing by leaps and bounds. Employer claims data is showing that these plans are saving, about 20% on the total cost of care, providing better health benefits. Employees are happy, doctors are happy, patients are extremely happy with the kind of care that they're getting now. It's been very bipartisan. So when the Affordable Care Act came around, the premise of the Affordable Care Act was we're going to give health care to every man, woman, and child in America. What did that mean? Did that mean primary care? No, it meant health insurance. And health insurance was going to be the only way you were going to be delivering primary care. So the only way you're going to get primary care is through your insurance plan, which we're going to mandate that you have and employers pay for. So we put a provision in the Affordable Care Act in Section 1301A3 that really was the place that the words direct primary care were invented. We threw the words in there because it was, in Washington, we called it Direct Practice Act. And direct primary care was a good way to describe what was happening with this. It's a direct payment, regardless of who's paying, whether it's the employer, whether it's the individual, it's a direct payment to the doctor to build that personal relationship with the physician. So fast forward, Donald Trump gets elected, and in his first budget proposal, Trump put in provisions in the budget to move not only to change the way certain health benefits are delivered with HRAs and association health plans and short-term plans. He said one of the ways we're going to scale this is through direct primary care, and we're going to bring direct primary care to Medicare and Medicaid. Monday, we were invited, after participating with CMS for about 2 years, trying to inform them about the ideas behind direct primary care and what were the best practices and what's working and what's not. On Monday, Alex Azar went before the country and the world at the American Medical Association and announced that they intend, through the Center for Innovation, through a demonstration program, to try to move 1/4 of Medicare and Medicaid patients into a primary care first direct pay arrangement with doctors. Now, this is not going to look like DPC that you all have come to know and love. But think about the political significance of the announcement that was made this week, just coming 10 years after we put the provision and really kind of just, you all in this room bootstrapped this and invented it and have sold it to everybody because it is a great idea. It is still a very bipartisan idea. So you have the Trump administration taking a provision that was in the Affordable Care Act, Obamacare, and trying to scale that to Medicare. So there are going to be 2 programs. One's called Primary Care First. It's designed to sort of fit the needs of a smaller practice. There will be some reporting requirements. It'll be a mix of a per member per month fee that will be offered to practices to take care of a certain patient population. There will also be an opportunity for up and downside savings. So already this doesn't look exactly the way like the way you guys do business. And then there are still some fee-for-service elements in it. There's a per-visit fee attached to it because, candidly, I'm not sure everybody trusts you that you're actually going to take the money and see the patient. So they want to make sure there's a lever in there so that you're seeing the patient. These are going to be evaluated vis-a-vis the existing Comprehensive Primary Care Plus demonstration. So if you already have a practice that's in CPC Plus, you won't be able to get into this right away. You'll be able to get into it in a year. But the intention is to launch these things this spring to seek applications and have the first practices being paid in this model by 2020. The second model is called direct contracting. It's essentially a fully at-risk model. So if you think about the kind of thing that Roshika Fernandopulle is doing in Medicare Advantage with IORA and some of the larger payers, more similar to that, it'll be a global payment. There's actually 3 different models, and I'm not going to go into super detail, but I'll be around the whole time if we want to talk a little bit more about some of the specifics behind this. But it's really going to be an interesting thing to watch. This is designed, these are voluntary programs. They're designed to test and evaluate the idea of moving to direct contracting with primary care physicians. But again, I emphasize that the Secretary of HHS, the head of CMS, got up and said, what we need in Medicare is primary care, and we need primary care first. So it was a big moment. It was an important step forward, and the coalition is going to work really, really hard to try to ensure that Medicare gets it right. So we've also worked really hard to pass laws in 25 states that define DPC as a practice of medicine, not the business of insurance. We've been pretty successful at that. We've got a number of states, eight more states this year are pending with laws out there. We welcome your enthusiasm and activity in getting involved in some of this. The purple states that are mentioned up here are all states that have had regulatory guidance that's favorable to DPC, saying it's not insurance. So this has been another effort of the coalition over the years, and it's been one that's been pretty darn successful. Half of the states now. So the big boogeyman in the room are these IRS rules around the interpretation of the relationship between DPC and HSAs. Right now, individuals that are eligible for HSAs are not eligible to fund those HSAs if they have a direct primary care agreement, because the IRS looks at this as some sort of other form of health coverage. Even though the Affordable Care Act rules and 25 states say that these laws can't, these plans are not insurance, the IRS rules are different, they need to be changed. So the Primary Care Enhancement Act is a legislative clarification. Very simply, DPC arrangements are not health plans or other coverage. You can take money out of your pre-tax HSA to pay for DPC fees, and DPC is not a health insurance plan for the purposes of this 223C of the Internal Revenue Code. We passed a version of this bill last year in the House of Representatives in a bipartisan vote. Candidly, it was on its way to being passed when, does anybody remember the government shutting down? And the Senate stopped working and pretty much everything blew up. But the good news is we have two extremely passionate champions for this bill. We have Senator Bill Cassidy, who's the gentleman on the left, or my left, I guess, here. Gentleman in the bow tie, Cassidy is a gastroenterologist from Louisiana, conservative Republican. Earl Blumenauer, liberal Democrat from Oregon. We have bipartisan support for this. We had to make some changes to this legislation for the sake of the score to the tax code. Even with the changes that we made, some of which we're trying to change and modify as we reintroduce the bill, this bill scored at $1.8 billion over 10 years. So a hurdle remains to get this thing completely across the finish line, so we need your help. We're going to be having our next fly-in September. We need you to come to Washington, help us lobby, join the DPC coalition, join the revolution, and help us keep fighting to make this happen. I think this is a year we can do it, but we're going to need your help. So thank you very much. I'll be here to take any questions.